first online symposium today, and it's my pleasure to welcome two speakers. And the first is Professor Pilotto. He is a chair of the Special Interest Group on Comprehensive Geriatric Assessment, and the other speaker is Professor Gaetan Gavazzi, who is also involved actively for many years in the Special Interest Group of Infectious Diseases. And welcome, both of you. Gaetan, can you hear me? I can't see you actually. I can't hear anything. So I only see and can hear Professor Pilotto. So hopefully the transmission is taking place. So I would ask the first speaker, Professor Pilotto, who will talk about the activities of the Special Interest Group, and then we'll talk about multidimensional approach to the older patient with SARS-CoV-2 infection. So Alberto, please, you can start. Hopefully everything is okay.
Thank you, Professor Topinkova. Please, can you see correctly the slide presentation?
We can't hear anything from the audience, actually.
Can you see my slide presentation just now?
Yeah.
Yeah. Okay. So a multidimensional approach to the older patient with SARS-CoV-2 infection. I have no potential conflict of interest to report. And I will start my talk from this point. The heterogeneity that we observe in old age depends from the interaction between different domain or dimension. The health status, mainly comorbidity of polypharmacy, the functional, cognitive condition and mood, mobility, nutrition, psychological, social, and economical aspects. All these domain or dimension are during the last period are explored by the geriatric medicine in order to obtain the clinical profile, the pathological risk and residual skills to develop the personalized care plan. During the last 35 years, the meta-analysis and a long series of randomized clinical trial and observational studies demonstrate that in different settings, in and out of the hospital and also at population level, the intervention by a multidimensional approach reduce mortality, institutionalization, and also readmission. This is true also in specific clinical settings such as orthogeriatrics, post-operative, the surgical setting, and in oncology, where the CZA intervention reduce mortality, post-operative complication, and may influence the way of treatment. Very recently, the special interest groups in systematic reviews and meta-analysis and in comprehensive geriatric assessment of the European Geriatric Medicine Society, the EuGMS, carried out an interesting umbrella review of health outcomes related to the comprehensive geriatric assessment methodology, with a strong methodology that include the only systematic reviews and meta-analysis of randomized clinical trials and observational studies. It has been possible to observe that these results, the comprehensive geriatric assessment carried out in the hospital reduce institutionalization of older adults at discharge, institutionalization after 3 and 6 months, and increase the discharge at home, reduce falls, reduce the risk of pressure sore, and at population level, reduce also frailty. Also in the surgical setting, there is a reduction in time to surgery, the length of hospital stay, the mortality, long-term mortality after 1 year of follow-up, and delirium. So the conclusion are that comprehensive geriatric assessment is beneficial in the hospital setting with a high grade of evidence, and also in surgery, orthopedics, and primary care setting, even if with a less strong evidence. Overall, all these findings support the use of a multidimensional approach in clinical practice, suggesting that also new research topics in different directions may be useful for tailored and personalized medicine. During the last year and a half, our attention, our life, our work was concentrated on COVID. And since the beginning, in March of the last year, it was clear that it was not only a problem of the old age and the comorbidity, but also frailty could be important in influence the prognosis and the trajectories of the infection beyond the chronological age. Frailty and multimorbidity may be relevant in order to have the evolution of the disease, both in the hospital and also outside the hospital, in nursing home residences, as well as in long-term care residents all over in the world, from Europe, Asia, and United States and Canada. At this point, most physicians start to include the concept of frailty in their clinical evaluation. But the problem is that which kind of models and which kind of tools we use, the functional model, the phenotypic model, or the accumulation deficit model, capture different way of frailty and different frail patients. So from a geriatric clinical point of view, it is a great agreement that the frailty condition is a multidimensional condition in nature, and that is linked to the health status, functional, mobility, cognition, mood, nutrition, physical activity, and social and economic aspect or dimension. And during the last 45 years, the geriatric medicine researchers develop and validate a series of tools and instruments that have a clinimetric approach to explore all these domains in order to have a multidimensional integrated expression of the frailty condition. Indeed, the most common frailty instrument that are reported in this excellent study, only few of these instruments adopt a multidimensional approach, and among these very few instruments based on a multidimensional methodology, the multidimensional prognostic index has been validated in both primary care in the hospital and during the last 2 years also in long-term care facilities. With this in mind, at the beginning of the COVID pandemic, The Special Interest Group on Comprehensive Geriatric Assessment launched a prospective observational cohort study in order to evaluate if the MPI can predict the admission of intensive care units, they evaluate if the MPI can predict in-hospital mortality, and also after 3 months of follow-up, the length of stay, rehospitalization, admission in long-term care facilities, and 3 months mortality. 2 cohorts were included in this project, 5 centers from Italy and 5 centers from Europe. So you can see here the data from the first cohort from Italy and data from 227 patients with COVID infection with a mean age of 80 years. As expected, the stratification according to the MPI low grade, moderate, and severe grade of the prognostic disease has an excellent value in predict mortality. Also, very important, an increase in 0.1 point of the MPI increase the risk of more than 40% in mortality risk. And also, the length of hospital stay is related to the presence of the MPI 1, 2, or 3 class, 16 days, 23 days, and 27 days, respectively in MPI 1, 2, and 3 patients. So the conclusion are that prognostic stratification was associated with a significant different risk in mortality, length of stay, and as regard the ventilation that in the MPI 3 patient is reduced compared to MPI 1. These findings are important because to introduce that prognostic factors based on CZA may be used in daily clinical practice. Indeed, this clinimetric approach gives us the opportunity to have other information. In this study carried out in 231 patients with acute respiratory failure in the pre-COVID period, demonstrate the NPI admission predict in hospital all-cause mortality, as well as the non-invasive ventilation failure. However, it has been possible due to the clinimetric algorithm characteristic of the MPI to identify a cutoff value in order to evaluate and assess if the use of non-invasive ventilation may be of success or maybe with a failure. The cutoff in this cohort was observed at a 0.84 of MPI. And so the conclusion of this study were that the MPI performed at hospital admission could identify the patients for the patient selection for non-invasive ventilation, and that subjects with a lower grade than 0.84 should be the optimal candidates for NIV treatment. With this in mind, we can observe the data of the second cohort of the MPI COVID-19 project, data from Europe. We included more than 500 patients with COVID infection, and as expected, the mean age increase with increase in the MPI grade. It increased the prevalence of female sex, and increase the MPI score, of course, as well as increase also the delirium prevalence from the MPI 1, 2, and 3, as you can see from this data of the 480 score. The ventilation, invasive ventilation, significantly reduced, and again, an increase of 0.1 points on the API, increase of 17% the risk of 3-month mortality. Very interesting, it was observed that the cutoff of 0.50 was very important in identifying patients that with the non-invasive ventilation had demonstrated and had a higher risk of mortality compared the patient with a lower MPI. So this is a clear demonstration that the use of a clinimetric possibility with a multidimensional prognostic index may be useful in identifying according their value, identify the usefulness to treat or not to treat with non-invasive ventilation. This is true also in outside of the hospital, in nursing home, as demonstrated in this excellent study in about 4,000 residents in 31 nursing homes in the Veneto area in northeast of Italy. You can see that, as expected, the MPI 1, 2, and 3 are a survival rate significantly different, but it was very important to observe that when we stratify patients according to the presence or absence of the COVID, the risk of mortality is higher in COVID patients independently of the mortality risk as assessed by the MPI. Indeed, the higher the COVID was associated with a higher risk of mortality compared to non-COVID patients, also considered the different grades of frailty. Is it possible to increase the predictive value of the MPI? Sure. For example, in these explorative studies carried out in community-acquired pneumonia before the COVID period, we demonstrated that including the procalcitonin serum levels, for example, to the MPI at admission, we can improve a significant ED, that it means the integrated discrimination improvement, while this is not true if we include the procalcitonin serum levels at the MPI value at discharge. In conclusion, MPI significantly predicted 1-month mortality, and procalcitonin significantly improved the accuracy of the MPI only at admission. Please observe that at discharge there is a very, very high accuracy, more than 84% in prediction accuracy of the MPI at discharge. What about the new advances in research and clinical practice in the comprehensive or multidimensional approach during the COVID pandemic era? It is clear that all the strategies for an anti-aging, the physical activities, nutrition, the social engagement, the prevention, chronic disease are reduced during this last period. The hospital are concentrate in this battle against the COVID, and inside the long-term facilities and the isolation, the problems are very, very high. But we have a new possibility in exploring new telemedicine, for example, and we need a very high level of home care services. So I will show you briefly three examples. For example, in this self-management program to treat chronic disease, in which inside of this European project, we develop and validate a MPI, a self-administered multidimensional prognostic index, and implement it in 5 countries in order to demonstrate that this self-management program reduce frailty as assessed with the selfie MPI score, especially in more vulnerable and frail participants with more chronic disease and lower cognitive performance and nutritional status. Another interesting example is the telephone, the tele-MPI, a version for the telephone administered multidimensional approach in patients at their home. For example, in this study, we demonstrate that it is possible with the telephone MPI, the telephone multidimensional approach, to identify patients at a risk of psychiatric disorders and at a risk of falls. And this is another interesting experience coming from the South Australia. In this hospital, this research using the machine learning to improve the accuracy of the multidimensional prognostic index in order to have and support a more precise clinical decision making. At the end, I will show this interesting data from Denmark. They use a record-based multidimensional prognostic index and compare the accuracy with the clinical frailty scale, demonstrate that there are no difference in predictive between the visual charts and the multidimensional based multidimensional score, continuous or divided in class. So the authors conclude that most probably clinical frailty scale may be used as a screening test, while the bedside MPI is valuable as a systematic application of a multidimensional approach, recommended to detangle complex physical and mental health needs among elderly, and also to plan an early discharge in the geriatrics and internal medicine wards. And at the end, the next afternoon, during the meeting of the Special Interest Group on Comprehensive Geriatric Assessment, we will launch this new project to have a brief MPI, a screening version of the MPI. The preliminary data carried out on 60 older patients demonstrate an excellent association between short, brief, and full MPI score, with only 3 patients outside of the limits of agreement at the Blandon analysis. And the brief MPI was demonstrate an excellent sensitivity, 93%, specificity, 75% to identify frail patient compared to standard MPI. At this point, this is my last slide. The new horizon in the multidimensional approach is as reported 5 years ago. The multidimensional approach has an evidence base that merits its implementation for older people with frailty, both in the hospital and in all other settings. How the comprehensive geriatric assessment can be implemented and tested in its effectiveness in clinical practice need also to be explored, and this requires the researchers and clinical practitioners work together to develop a better evidence base in novel settings, including COVID-19 condition. Thank you very much for your attention.
Okay, thank you, Alberto. It was an excellent lecture. and I think everybody enjoyed the lecture and the importance of comprehensive assessment. And I am very happy that you at the end compared, for example, the clinical frailty scale and the MPI, because that might be questions from the audience. However, we are now just a little bit behind our time, so let's wait if we have time for more questions. And I would like to invite another distinguished speaker, and it's Gaetan Gavazzi from Grenoble University Hospital, who is geriatrician, professor of geriatrics, and also has long stay interest in infectious diseases. And he will present on rationale of antibiotic stewardship with procalcitonin in older patients. So Gaetan, please.
Thank you, Eva. So I'm waiting. It's quite funny to be invited in a so complex geriatric assessment to deal with only a small procalcitonin biomarker. So I don't know if I will convince you or something else about the use of a simple marker in front of a whole geriatric story from the beginning. It's more than 1 century. So I would say at the beginning that about infection and the relationship between infection and older population, we can say something during one month, I say. But to resume, infection is the third, fourth cause of mortality, of all mortality. But now with COVID, perhaps it's much more. I don't know. And if you look at the secondary and direct impact of infection, probably it's more. There is a deleterious impact on nutrition, on function, and on social, as I already said. We have the problem of atypical clinical presentation because of de-escalation, because of organ decompensation, and because of less fever in some as a cardinal point in the diagnosis of infection. This means that the diagnosis is more difficult to reach, and you know that. When you say that there is a therapeutic delay after and an increase in appropriate antibiotic therapy and antibiotic resistance. All of these is thousand manuscript and article which has been published on that. Well, mean that we have an urgent need to improve all of that, but how can we deal with it's perhaps the role of biomarkers. And I'll try to give you something about procalcitonin. Procalcitonin is known now for more than 30 years. The first paper was in Lancet in 1999, and it was as a diagnostic tool. It was the first aim was to decrease antibiotic use in infection, and of course it was observational studies. After it has been studied as a prognosis tool, and particularly in bacteremia, because bacteremia is a sure infection. When you have bacteremia, you're quite sure that you have an infection. When you have a respiratory tract infection, sometimes it's not really true. When you have a urinary tract infection, half of the urinary tract infection you treat are not urinary tract infection, and they don't need antibiotics. It's the story. And finally, the question that has been asked for me today is antibiotic stewardship. And as you see, antibiotic stewardship can not carry out observational study, but it's interventional study. And I think if there's a first message, take-home message is stop observational studies in older population and make interventional studies, please. It's better. So the idea of antibiotic stewardship is to change a bit the mind of infectiologists about the duration of antibiotic therapy and much more individualized antibiotic duration, of course. So basal procalcitonin, I will try to go fast because we are quite late, but it has been published there a few years ago that there are a baseline procalcitonin level are increased in elderly. But when you look at the paper, you see that it was associated with low-grade inflammation and lower renal insufficiency, in fact. And they are all been studied at emergency department. So when you take some data of people who are at emergency department, for sure they are there for something. So I'm not sure that it was a real baseline. But the second takeaway is that procalcitonin there is no procalcitonin at basal level in elderly, although there is a basal inflammatory, low-grade inflammation in older population. What we can learn about the first observational studies, this is meta-analysis, which has been a systematic review, about the use of procalcitonin. What we can say that now we need to use only PCT, very sensitive assay. There was in this paper a variability of PCT assay. Threshold was different, sites were different. Then the usefulness of the procalcitonin as a diagnosis tool was very questionable for population. When you look at that for CRP, which is in France very used by residents, by medical doctor, first 1, 2, until 5 CRP during 10 days of hospitalization. So it means, what does it mean? In fact, when you look at the role or the impact of CRP to C-reactive protein, to diagnose infection, as you can see, the sensitivity was in between 10 and under 100, and the specificity was a very rare CRP, more than 150 or more 175 milligrams per liter. So at these times, if you have no CRP, you can have an infection, because if your infection begins quite early, you need 48 hours to have a CRP which increase. So if you are too early, it's not used, and of course, you have real bacteremia with negative CRP. And when it's very high, you have a lot of other pathologies which can give you the same thing. So do we have to stop CRP measurement in all this? In some for diagnose infection, of course. For other things, it's important. But for CRP, I'm not for infection, I'm not sure it's quite useful. Finally, the likelihood ratio was quite low, and different assay, different cutoff, as I said before. I go on. So the first take-home message for procalcitonin as a diagnosis tool, there are a lot of limitations. We cannot be used on first, and work is not yet well done, I think, about urinary tract infection or overinfection. But at that time, I think it's not a very good tool. What about as a prognostic tool? As Alberto presented, when you add the PCT with other scores, you can add something. But much more important, I think, it's because, as I said before, RTI, community-acquired pneumonia, urinary tract infection, we are not sure of the gold standard is not very well defined in older population. So when you look at bacteremia and you use observational study on bacteremia, you are quite sure. So I will give you some data about bacteremia. In general population, this systematic review is quite impressive. You have with one PCT, at one time, at the nearly same time of blood culture, you can have a ROC curve at 0.89, meaning that when a PCT is negative or under 0.5, you have a negative predictive value at more than 95%. It's like the D-dimers in pulmonary embolism. Has the same negative predictive value. So, we'll say this exists in adult population. What about procalcitonin bacteremia in old? Only 2 studies which say that, but it was in youngest population, 65 plus, and one time in 75 plus. There was only one study, and we performed a further one, but it was, of course, it's observational, it's retrospective, but we found the same thing, comparing CRP here in red and in blue PCT. That's not completely crazy, but when you use the same threshold that has been defined before, we find a negative predictive value of 94. There is a limitation we can discuss about that because it's retrospective, and inside this there are, of course, bacteriemia associated with pneumonia, with urinary tract infection, enterocolitis, which you will give antibiotic for that. So we need now real prospective studies using PCT like that. So TOM2 is procalcitonin as diagnostic tool. No, but may be used not to initiate antibiotics in patients with suspected bacteremia. But when we are sure that there is an enterocolitis or diverticulitis, you will give antibiotics. Okay, it's not important. But when you think, perhaps I will not give antibiotics to this person because I'm not sure, don't forget that 25% of the bacteremia are primary bacteremia without any portal of entry. So perhaps it could be interesting. But no interventional studies has been performed in older population. So the thing we can discuss here is when you have no gold standard, why do you use antibiotics? We use antibiotics to help people to be better. But if I ask to you, which is the mortality rate of invasive pneumococcal infection without antibiotics? I would say it's only 50%. It was before published in New England several times by William Osler, 50%. It means that if you forget to give antibiotics, 1 patient out of 2 will recover without you. So, humility. PCT, so it means that we need antibiotics because now it's 15% of mortality. It means it's better. But which is the quantity of antibiotics you need for 1 infection at a moment, and perhaps you will get 2 pneumonia in your life. First time you need 3 days, and sometimes the other times will be 10 days. It depends on the inoculum and the relationship in between you and the pathogen, meaning that we need to individualize antibiotic duration. And this, you can do this at that time with clinical parameters and also with perhaps with PCT. There was a really recent, and I give you the opportunity to see that the background is here. I will say that when you are under 0.25 or 25, you can stop. This is the idea. It's when you have a PCT at a time under this level, you can stop. Of course, based on the clinical judgment, of course, and you can begin like this, like that. What is published about that? A better use in sepsis patient, Schwetz, the team of Beat Müller and Philip Schwetz published many things about that, and now you have a two Cochrane review which say that in RTA, in respiratory tract infection, you can say that nearly 64% at 7 days will not have any antibiotics. And if you look well, here you have after 4 days, nearly 1 out of 3 will stop antibiotics, which is not quite used in your daycare, I imagine. This means that at 5 days, you can imagine if a PCT level measurement is done, perhaps you will stop half of the antibiotics in half of the population. I put 7 days because in France now, the idea of infectiologists said, more than 7 days of antibiotics, it's too much, whatever the diagnosis. So it's not true.
Kaetan, we only have 2 minutes. Two minutes. Okay, I'm sorry.
It's nearly finished.
Very sorry.
So the idea was to go further. So the duration of antibiotic treatment, it's the paper you have to read, and with that it will be enough. It's a systematic review with 14 trials, but in ICU, 12 in emergency department and medical ward, and 2 in primary care. It's nearly 9,000 patients, more than 65 years. What you can look at in the in all studies, you decrease the number of days of antibiotics. It's quite true. And the outcome, which has been, the outcome was the 30 days mortality rate. And as you can see, it's not different, but there is a tendency that it is better in procalcitonin group. But because of this study, it doesn't reach. But there was no specific studies in elderly population, and we performed that a few years ago. It was multi-center studies, and it was for 80 plus, and people who were included received antibiotics for less than 3 days. It was only pneumonia by CT scan or chest radiograph, but nearly all CT scan. There's not a lot of people at the end, but 50 in the PCT group and 57 in the other. The population was quite similar, and the more important, the pneumonia severity was the same. With, as you can see, many people, nearly 80% in each group, have a fine score or a curve score, which is the highest, meaning the highest mortality rate, of course. The PCT level at admission and the evolution was the same in the both group. And at the end, you can see that each two days we try to stop antibiotic. This is at the inclusion, after 2 days after the inclusion, and we stop already nearly 15%, and after six days, it was half of the population. So, of course, it was significant. And finally, we can say that in the per protocol, it was better because some people use PCT, but finally decided not to use it. And more important, finally, that 50% of people need less than 6 days. The outcome was the same, and the algorithm adherence, it was only 1 out of 2, meaning that we can implement better, of course. So my last take-home message is PCT-guided antibiotic treatment significantly reduce antibiotic exposures in older population without increasing mortality. But keep in mind, and it's for the geriatric assessment, a biomarker is only a part of a diagnosis strategy and how we take charge of population. And finally, the key words would say validate for tomorrow, validate threshold for different common infection in their old population, and perhaps with that, we can say that there is no urinary tract infection and stop to initiate antibiotic in this kind of population. And we need studies to use PCT as a point of care, and of course, comparatively with normal recommendation for the duration of antibiotic therapy. Thank you for your attention.
Okay, thank you, Gaetan. Thank you both for excellent lectures. And unfortunately, we don't have time for questions. However, if you have more questions, you may see both colleagues at the SIG group meeting. And this is comprehensive geriatric assessment starts today 4:30, and vaccines and infectious diseases start 6:30 Central European Summer Time. So
thank you
for those, okay, thank
Bye.
you very much. So thank you, the audience, thank you both the speakers, and we see each other in the afternoon. Thank you. Bye-bye.